Digestion begins in the oral cavity with both mechanical and chemical breakdown of food. Chewing motion breaks down food particles and mixes food with saliva secreted from salivary glands. There are three salivary glands that contribute secretions to saliva. The parotid glands contribute a serous fluid rich in amylase. Amylase is a digestive enzyme that begins carbohydrate digestion. The submandibular glands secrete a primarily serous fluid that also contains some mucus. Mucus secreted from the sublingual glands helps bind food together and acts as a lubricant during swallowing. As food is swallowed, it enters the esophagus and is moved downward by a wave-like muscular contraction called peristalsis. The contractions progress from the superior end of the esophagus to the gastroesophageal junction, where the contents of the esophagus empty into the cardiac region of the stomach. The lining of the stomach secretes gastric juices that contain digestive enzymes. Peristalsis churns and mixes the food with gastric juices while moving the food toward the first part of the small intestine, the duodenum. In the duodenum, food is digested even further. The bile duct from the liver and gallbladder and the pancreatic duct from the pancreas all empty their secretions in the duodenum. The bile works to break down fats, while the pancreatic enzymes aid in the digestion of other food particles. Together, these digestive juices help prepare the food so that the small intestine can absorb as many nutrients from the food as possible. The majority of the absorption takes place in the second portion of the small intestine, a 3-foot section called the jejunum. As the food travels through the jejunum, it's gradually broken down into smaller and smaller particles. Folds line the walls of the intestine and act to increase the absorptive surface area. The green nutrient particles and the yellow fat particles get caught in these folds and are absorbed into the intestinal wall. Larger, less digested particles are pushed onto the large intestine, where much of the water they contain is reabsorbed before being expelled from the body. A closer inspection of the folds reveals that the intestinal wall is covered with thousands of finger-like villi. A network of tiny blood vessels called capillaries runs just below the surface of each villus. These capillaries absorb the available nutrients in the intestine and transport them to the liver. The yellow fat nutrients are absorbed into a vessel called a lacteal that carries them to the circulatory system. Nutrients absorbed by the blood in the villi are carried to the liver by way of the portal vein. In the liver, the blood is filtered and the nutrients are extracted and processed. After processing, the nutrients are either stored for future use or released into the bloodstream to be used throughout the body. Teeth grind food during mastication. The exposed part of a tooth, or the crown, is covered with enamel, which is the hardest substance in the human body. The crown consists of rounded projections, or cusps, that facilitate the grinding process. Over time, food particles can cling and accumulate in the grooves between the cusps and between the teeth, forming a sticky plaque. Bacteria, such as Streptococcus, will flourish within the plaque, eating and digesting the sugars and carbohydrates. As a result, bacteria produce acidic byproducts that are harmful to the teeth. Normally, saliva will neutralize these acids, but plaque provides a barrier that prevents saliva from reaching acid that is concentrated around the tooth's enamel surface. From a cross-sectional view, the tooth consists of the exposed crown supported on a neck with roots that project into the mandible or maxillae. There are 3 tissue layers that make up the tooth: the hard enamel, the dentin, and a central region known as the pulp. Bacterial acid from plaque begins to erode the surface of the tooth, dissolving the enamel and forming a cavity or dental caries. This begins the process of tooth decay. The enamel contains no cells, so no pain is experienced at this point. As the cavity progresses, bacteria can penetrate the enamel and dissolve a crater in the dentin layer. Eventually, the cavity is extended into the soft pulp, where the destruction of pulp tissues leads to inflammation and infection. As extensive destruction continues, a pulp abscess made up of pus and dead tissue may form. Stimulation of the nerves causes the sensation of toothache and eventually severe pain. The abscess can spread into the surrounding bone and could cause serious problems if left untreated. Endoscopy is a procedure used by physicians to view, sample, or repair the passageways of the digestive tract. In this video, the endoscope is introduced through the oral cavity, passed through the pharynx and into the esophagus. We are now passing through the gastroesophageal junction. Notice the rugae lining the stomach. Upon closer examination of the stomach, the muscular folds called rugae that make up the stomach lining are clearly visible. The rugae gradually smooth out as the stomach fills, permitting stomach distension. A cross-section of the stomach lining reveals that in between the rugae are gastric pits, which are the openings of the gastric glands. The gastric glands are lined with different types of cells that contribute various components to gastric juice. Chief cells and parietal cells make up the gastric gland. Pepsinogen is secreted by the chief cells, and the parietal cells secrete hydrochloric acid. Hydrochloric acid converts pepsinogen into pepsin. Pepsin is the key component to gastric juice and is a potent digestive enzyme. By splitting protein molecules into even smaller parts, pepsin begins the digestion of proteins. Normally, gastric juices are secreted in the presence of food. Stress and smoking can also cause the stomach lining to secrete gastric juices. In the absence of food, the acidic juices erode the lining of the stomach, leaving an open sore that may bleed. This open sore is called an ulcer. Recent research has shown, however, that a bacterium, Helicobacter pylori, may be a major factor in ulcer formation. The use of antibiotics to kill the bacteria has proved quite helpful in treating many patients with ulcers. Bile is stored in the gallbladder. Normally, the cholesterol in the bile remains in solution. Under certain conditions, the cholesterol may precipitate and form solid crystals. If this process continues, the crystals grow larger and become gallstones. The stones may block the flow of bile, causing pain and jaundice. Gallstones may be removed surgically. The lining of the small intestine is characterized by numerous circular folds called plicae circularis. The plicae are lined with finger-like villi. From a cross-sectional view, the villus contains a network of capillaries which surround a specialized lymphatic vessel known as a lacteal. The epithelium of an intestinal villus consists of columnar cells which are covered with microvilli. This succession of folds and projections increases the surface of the intestinal lining for efficient absorption. Carbohydrate digestion is completed by enzymes in the small intestine. Carbohydrates are absorbed by the villi and then enter the capillary. Fat digestion occurs primarily in the small intestine. Fat molecules are digested and absorbed into the epithelial cells of the villus. The fats are formed into clusters called chylomicrons, which pass into the lacteal. Lymph carries chylomicrons away from the villus. Protein digestion is completed in the small intestine. Proteins are broken down first into peptides, then into amino acids. These are absorbed into the villi, then into the capillary. A physician performing a bronchoscopy views the passages of the respiratory tree using a flexible tubular camera that is inserted through the mouth or nasal cavity. This procedure can also be used to remove a foreign object or biopsy the respiratory system. Notice the numerous passages of the bronchial tree that air can pass through. The mechanics of breathing involve changing the volume and pressure of the thoracic cavity. By using the principles of Boyle's law, one can see that the pressure in the thoracic cavity is inversely proportional to its volume. When the intercostal muscles contract, the ribs are elevated. At the same time, the diaphragm contracts. These events expand the thoracic cavity, decreasing its internal pressure. The lungs expand, filling the thoracic cavity. The resulting pressure in the lungs is lower than that outside the body. Air enters the lungs until equilibrium is reached. When the diaphragm and the intercostal muscles relax, the thoracic cavity recoils. The resulting increase in pressure causes the air within the lungs to be expelled. The pressure of a given quantity of gas is inversely proportional to its volume. Increasing volume results in decreasing pressure. Decreasing volume results in increasing pressure. Increasing volume causes a decrease in pressure, which causes air to rush in as the pressures reach equilibrium. Decreasing volume causes an increase in pressure, which causes air to be expelled as pressures reach equilibrium. The process of exchanging gases between the atmosphere and the body's cells is called respiration and involves several events, including breathing. As we zoom into the body, we can observe the respiratory system during gas exchange. Air passes through the alveolar sacs to the alveoli, where gas exchange occurs. In this cutaway view of an alveolar sac and its capillary bed, the process of gas exchange is easily observed. During inspiration, atmosphere air fills the alveoli and gas exchange occurs between the alveolar and capillary epithelia. Oxygen in inspired air is represented as a white gas. Carbon dioxide in expired air is represented as a blue gas. Notice the changing color in the red blood cells during gas exchange. Now let's zoom into a higher magnification view of gas exchange at the respiratory membrane. Red blood cells in the capillary adjacent to the alveolus release carbon dioxide and bind oxygen. Research throughout the last few decades has demonstrated significant health risks associated with cigarette smoking. Examples of these risks include emphysema, chronic bronchitis, lung cancer, and inhalation of carbon monoxide. Carbon monoxide is produced as a cigarette burns. This odorless and colorless gas is inhaled with cigarette smoke into the lungs. As smoke passes through the air passages, carbon monoxide is carried to the alveoli, the small air sacs in which oxygen exchange to the blood occurs. As blood passes through the alveolar capillaries, oxygen in the alveoli is attracted to deoxygenated hemoglobin located on the surface of the blood cells. However, carbon monoxide has a 200 times greater affinity for hemoglobin than does oxygen. Carbon monoxide molecules bind to hemoglobin and can prevent oxygen from reaching the body's tissues. The combined hemoglobin and carbon monoxide molecules are called carboxyhemoglobin. Although the levels of carbon monoxide produced in cigarette smoking are not immediately dangerous, research suggests that reduced oxygen transport to fetal tissues may contribute to the lower birth weight of babies born to mothers who smoke. There may even be a correlation between smoking during pregnancy and incidence of sudden infant death syndrome. Each red blood cell contains 280 million hemoglobin molecules. Hemoglobin is folded protein with 4 iron-containing heme groups. Each heme unit binds with 1 oxygen unit. As a hemoglobin unit becomes oxygenated, its color changes to a brighter red. Collectively, this molecular color change is evident in the bright red color associated with arterial blood. Asthma is a condition characterized by breathlessness and wheezing. To understand how asthma causes shortness of breath, one must look at the normal respiratory system. Air enters the lungs through a large tube known as the trachea, which is supported by concentric rings of cartilage connected to each other by annular ligaments. The trachea splits into a right and left primary bronchus, and from there, each primary bronchus subdivides into secondary and tertiary bronchi. Tertiary bronchi continue to branch into smaller tubes called bronchioles. Unlike the larger tubes, bronchioles do not contain cartilage and must rely on smooth muscle in their walls to keep these airways open. The smallest and final branch of bronchioles, called terminal bronchioles, end blindly into the alveolar sacs. Alveolar sacs are made up of grape-like clusters of alveoli. Within these alveoli, gas is exchanged and vital oxygen enters the bloodstream. Throughout the bronchiolar tree, mucus is secreted from specialized cells in the walls to trap foreign particles and irritants that may be in the air we breathe. The walls consist of cells that are covered with cilia, whose main role is to push mucus up and out of the bronchiolar tree, disposing of the trapped particles and irritants. Looking at a cross-section of a bronchiole, it is evident that under normal conditions, there is little resistance offered to the incoming rush of inspired air. The wall of the bronchiole is relaxed and provides an open airway. Asthma is a chronic condition in which various irritants cause bronchioles to become inflamed. Some of the most common irritants are dust mites, pollen, smoke, stress, and infections. These irritants can cause a cascade of events, such as the release of leukotrienes and histamine from leukocytes and mast cells. The result is inflammation, overproduction of mucus, and bronchial constriction. All 3 block the airways, making it difficult for air to move in the lungs and thus triggering an asthmatic attack. There are several treatments for asthma. The most common is epinephrine and related compounds. Epinephrine stimulates beta-adrenergic receptors in the bronchioles and promotes the dilation of bronchioles. Epinephrine can be inhaled as a spray to open up clogged bronchioles, which in turn will relieve the symptoms of an asthmatic attack. One of the primary functions of the kidney is better understood at the level of the nephron. In forming urine, the nephron functions to remove metabolic wastes from blood while regulating the volume and composition of body fluids. Urine formation begins in the renal corpuscle, where blood passing through the glomerulus is filtered. Filtrates include water, ions, and other solutes, which are filtered out of the blood and into the capsular space to begin urine formation. Urine passes into the proximal convoluted tubule, then into the nephron loop. The nephron concentrates urine by the process of the countercurrent multiplication system. The countercurrent multiplication system is basically the means by which water and sodium are extracted from the filtrate as it passes through the tubules toward the collecting ducts. This system is called countercurrent because of the dynamics set up by the hairpin turn of the loop of Henle. The direction of flow in the descending limb of the loop is opposite from the direction of flow in the ascending limb. By flowing in opposite directions in such close proximity, a unique interaction occurs. The loop of Henle dips from the cortex of the kidney into the medulla and is surrounded by the medullary interstitial fluid. The countercurrent multiplication system is responsible for not only elevating the concentration of urine in the loop, but more importantly, it elevates the concentration of the interstitial fluid as well. To explain the countercurrent multiplication system, we must first imagine the loop filled with a stationary column of glomerular fluid, which includes water, salt, and urea. At first, the concentration of the glomerular fluid and the surrounding interstitial fluid will be equal at an osmolarity of 300 milliosmoles. Within the walls of the thick segment of the ascending limb, special pumps extract salt, sodium chloride, from the fluid and transport it to the interstitium. The two areas no longer have an equal osmotic pressure and a gradient has been established. Within the thick segment, the concentration is at 200 milliosmoles, whereas in the medullary tissue, the concentration is at 400 milliosmoles. Over time, a net diffusion of salt into the descending limb and a net diffusion of water out of the descending limb results in a balance in osmolarity between the descending limb and the surrounding interstitium. Because the thick segment is still actively pumping out salt, the osmolarity of the ascending limb is still 200 milliosmoles, and the interstitium and descending limb are balanced at 400. Salt accumulates in the medulla while water is drawn out of the fluid in the descending limb. Water is removed by the vasa recta, which are capillaries that surround the loops. In real life, operation of this gradient occurs while the fluid is flowing. Fluid flowing in from the proximal tubule and out to the distal tubule along with the constant pumping of salt into the medulla contributes to the multiplication of this gradient. As fluid follows the path of the loop, an increasing amount of water is extracted as it reaches the bottom, and an increasing amount of salt is pumped out as the fluid reaches the top. The more salt pumped out, the higher the concentration in the medulla. The higher the concentration in the medulla, the more water is extracted. Eventually, the levels of osmotic pressure are equal horizontally, with the highest value being at the tip of the loop. This level is at 1,400 milliosmoles per liter, which is also the value of the maximal osmolarity of excreted urine. As you can see, fluid becomes more concentrated as it rounds the loop, but it immediately becomes rediluted as it reaches the top. Final concentration of the fluid occurs in the collecting ducts as it must travel back through the concentrated interstitium of the medulla on its way to the calyces. Urine is concentrated even further in the collecting ducts. The collecting duct must transport urine back through the concentration gradient formed by the nephron loop. The walls of the collecting duct are permeable to water, but not to salt. Therefore, an increasing amount of water is drawn out by osmosis as the fluid travels through the gradient. The gradient provides the force for the concentration of urine, but the rate is determined by the amount of antidiuretic hormone, ADH, in the blood. An increase in ADH in the blood causes the collecting ducts to become more permeable to water. Less urine is secreted and it is more concentrated. A decrease in ADH results in a decrease in water removed, thus a larger volume of more dilute urine is excreted.